Disorders of sodium are actually disorders of free water. We use sodium as a surrogate for how much free water there is in the body. That is to say, sodium is a measure of tonicity, how much stuff there is in the blood, rather than how much salt. So when you say disorders of sodium, think of disorders of water. That will become apparent as we go through this lecture. Let's start off with a general concept of tonicity. The body is just like in general chemistry. There are two compartments separated by a semi-permeable membrane. This is the blood, and this is the cells. Normally, there is homeostasis or equilibrium. There's just as much volume as there is stuff. If you have hyponatremia, that is, too little stuff in the blood, the system is going to change. You have too little stuff in the blood, and the cells are normal. If you remember from general chemistry, water is going to move from a concentration that is lower to a higher concentration. So water is going to move from the blood into the cells. This is a process that we call swelling. In order to balance out the tonicity, the cells take on more fluid. Swelling is bad, and it causes symptoms. In the opposite condition, that is hypernatremia, where there is too much stuff in the blood, initially you start off with too much stuff in the blood. Water is going to go down its concentration gradient, so water is going to go from an area of too little stuff to too much stuff to balance it out. Water is going to come out of the cells. That causes the cells to shrink, which balances out the tonicity, but shrinkage is bad, and that causes symptoms. But it's not the swelling or the shrinking that causes the damage. It is, as you remember in calculus, the dp dt. That is to say, it is the change of the sodium or the tonicity over time. So rapid changes are going to cause significant damage. If the body has time to adapt, that is, the change occurs slowly or is not that severe, it may not provoke any symptoms at all. So as you start thinking about disorders of sodium and disorders of free water, see that it's either cells swelling or cells shrinking as water shifts. And the severity of the disease is going to be the magnitude of the change, this is the change of sodium, over how fast it happens. If it happens fast, it's bad. If there's a big change, it's bad. But small changes don't impact symptoms that much. Before we get into the interesting stuff in this lecture, I want to briefly tell you how to fix these diseases. Hypo and hypernatremia can be separated into three categories: mild, moderate, and severe. And I will tell you that these are fairly arbitrary distinctions. Severe is going to be the, oh my God, I got to fix this guy right now, he's seizing and actively dying, where mild is going to be the numbers off, but there aren't any symptoms. And moderate is somewhere in between. It's going to be up to you to determine where they are. There's no criteria that define mild, moderate, or severe, but it's going to be a sense of the clinical picture. If they're mild, and that is they have small disorders of free water, all you're going to have to do is replace it PO. In the sense of hyponatremia, they're going to need a little salt. You feed them some Gatorade, they get better. Same thing with hypernatremia. That is, they just need a little bit of PO-free water. Give them some water to drink, and they get better. On the other hand, if they are severe, they may not be able to drink anything. Someone who's got severe hyponatremia may be in a coma or actively seizing. These patients need intravenous infusions. In the case of hyponatremia that is severe, you replete with hypertonic saline. Being careful about how much you give. If you correct hyponatremia too quickly, that is, the change in the sodium over the change in time is corrected too fast, you cause centropontine myelinolysis. That is a spastic quadriplegia as all of the neurons demyelinate. So you have to be careful with how fast you correct because you can provoke symptoms. If the body was used to a shrunk state and all of a sudden you rapidly replete it, it will be like them swelling. For moderate cases of hypo or hypernatremia, they're going to get intravenous fluids. And generally, you can just give normal saline. While normal saline has 154 milliequivalents of sodium, it is isotonic. And if they have functioning kidneys, the kidneys will balance out the sodium, so you give them a slow rate of just some volume, and they will generally get better. For the case of severe hypernatremia, you can use half normal saline or D5 water. The only thing you're going to pay attention to is whether or not you use 3% sodium chloride. Whether they can do it PO or IV doesn't really matter, but you have to watch out for the person who has severe hyponatremia, as indicated by the number less than 110, or seizures, or coma. That person needs more rapid correction because the symptoms are so severe. There are online calculators you can use to determine how fast and what rate you should do it at. And in general, you never correct sodium by more than 1 milliequivalent per hour. And your goal should be half a milliequivalent per hour unless they are actively seizing, in which case you need to rapidly correct them. But if you go faster than this, you put them at risk for centropontine myelinolysis, and while it may take a day or two in the hospital to get them better, going slow, better than going fast. All right, so this is an overview of the treatment and some of the pathophysiology of tonicity. Let's talk about what happens when you actually have some hyponatremia in a real patient. They're going to come in, and you're going to get a lab. They're going to show hyponatremia. The first step is to compare the calculated and the measured serum osmoles, because that's what you actually care about. Sodium is supposed to be a surrogate for how much tonicity, how much osmoles are in the blood. But it may be the case that something else is taking up the space. So to calculate the serum osmoles, and this is an equation that's worth committing to memory, it's 2 times the sodium plus the glucose divided by 18 plus the BUN divided by 2.8. And a way to remember that is it's 2 from the sodium, 8 from the glucose, BUN divided by 2.8. You take this value and you compare it to a measured serum osmoles. If the measured osmoles are significantly greater than the calculated, it means that something else other than sodium, glucose, or the BUN is taking up the space. So in the case where the measured osmoles tell you that it's actually hypertonic, it means the sodium lied to you because something else was taking up the space. This is going to be toxic ingestions. And this is really where you should start thinking about the alcohols. In particular, ethylene glycol, isopropyl alcohol, and methanol. But where they often throw this in on test taking is going to be the glucose. For every 100 glucose above the first gives you a correction of sodium of 1.6. Let's just do an example so this becomes more concrete. If the glucose is 1,000, it is 9 100ths above 100. That means you should correct the sodium by 9 times 1.6. 9 times 6 is about 50. So 5, 9 times 1 is 9. Correct by about 14 or 15 sodiums back on. Say that one more time. 900 glucoses above the first 100, so that's 9 100ths. You correct the sodium by 9 times 1.6, which is about 15. You take whatever the sodium is on your BMP, you add back 15. You'll do this a lot, and you can use this actually as the nurses call you and say, I have a critical value, the sodium's really low. You ask, what's the glucose? Do the mental calculation in your head and tell them it's okay, just get the glucose down. There will be another time where the measured and serum osms both tell you that actually they are isotonic. Again, the sodium lied to you. This is a condition in which fats and proteins disrupt the laboratory value of the sodium. Don't worry about this. If you see that the serum osms are actually normal, they don't have a disorder of free water, you ignore it. The interesting part, and is what really where a lot of people like to jump to, is actually when the measured osms and the serum osms are both low. That is a true hypotonic hyponatremia. At this point, you have to use your history and physical to determine the volume status of the patient. And when you take step 2, it's really easy because they're going to give you clear-cut examples. But it's actually a lot harder in life. And I'll show you why. There's 3 possibilities. One is hypervolemia. Too much fluid. One is hypovolemia. Too little fluid. And of course, just right, euvolemia. Now, if the patient has fluid from their toes to their sacrum, they have a history of heart failure, or nephrotic syndrome or cirrhosis, and they are so clearly volume up, the answer is hypervolemia. And that's easy to tell. If someone is clearly hypervolemic, you can see it. And if they are hypervolemic, they need diuresis. Mobilize that fluid and the sodium will correct itself. What becomes challenging is the differentiating between euvolemia and hypovolemia. What you learn in medical school is that people who are hypovolemic are going to have skin tenting and sunken eyes and dry mucous membranes. It turns out that in adults, particularly in the elderly, you are going to see that those have a likelihood ratio of 1. That is, if you find them, it doesn't matter. If you don't find them, it doesn't matter. They may still be hypovolemic. So what you have to use instead is more of the history. And the history is going to give you examples of why they might have either increased free water loss or decreased access to free water. It's going to be things like fever and tachycardia, heat exposure, or water restriction. That is to say, the septic patient at a nursing home didn't know they had a UTI, who started breathing really fast and had a fever, has insensible water losses, and because they're old and in the nursing home, they're not able to express the need for free water, so they don't get the water they need. That person's going to be volume down. You won't be able to do this very well in a physical exam like you were for hypervolemia, but you're going to have to use the history to determine, are they hypovolemic? Euvolemia is going to be the absence of hypovolemia and hypervolemia, and you'll see that differentiating these two, euvolemia from hypovolemia, is very difficult. In a test-taking sort of way, if you find hypovolemia, you're going to check a urine chloride to determine which direction you go in. In a practice standpoint, that's not useful. Get rid of this idea from practice and just give them fluid. If you think they're volume down, the treatment is intravenous fluid. If it makes them better, you were right. They do indeed have hypovolemia, and the treatment is more fluid. If you give them fluid and they get worse, the answer is that they were euvolemic and should have been water restricted, which is the treatment for the euvolemic hyponatremia. And now that you know they are euvolemic and need to be water restricted, you can work on determining the etiology. So a 500 or 1000 cc bolus, they're going to get better if they're hypovolemic, they're going to get worse if they're euvolemic, and you should have been able to tell that giving someone intravenous fluids who is already volume overloaded was a bad idea. Once you get into the euvolemic category, you start thinking about the mnemonic RATS. That is going to be renal tubular acidosis, usually type 4, Addison's disease, thyroid disorders, usually hyperthyroid, and after you rule out renal tubular acidosis with urine electrolytes, Addison's disease by assessing the aldosterone levels and the cortisol levels, thyroid disease by assessing a TSH. If all of these are normal, then you are going to determine it is SI-ADH. Addison's disease, the disease itself, as you'll learn in endocrine, is a loss of the adrenal glands, so you'll lose both aldosterone and cortisol. People like to jump down to SI-ADH, and you might have medical students that get excited they found euvolemic hyponatremia and will jump here. This is a diagnosis of exclusion. And a lot of people don't feel comfortable with using this process. As you might have guessed, there's not very concrete evidence for which category to go into. And so giving someone fluid when you're not sure what volume state they're in can be devastating. So there is a way of ordering tests before you intervene to try to get an idea of what's going on. This is a model we're going to use multiple times in this series, so I want you to commit it to memory. Every time I'll explain it as though it's the first time, and you should start to see it in your head over and over again. It's going to be the nephron. The nephron is set up in a certain way. This is the glomerulus, the loop of Henle, distal convoluted tubule, and the collecting duct. What matters is here at the JG apparatus, the macula densa. And I want you to see this as a switch. Now I live in New Orleans, so it works in New Orleans when I explain it this way. It's a Katrina switch. There are light switches in the house that I bought after Katrina that were thrown together by contractors that just are backwards. It's not one of those light switches that you have two of them, so one is down and one is up and the light's on. I mean, it's one light switch where down is on and up is off. This works only if you commit that to memory. It's a Katrina switch, so it's backwards. Down is on, up is off. Because you probably learned in first year medical school that the JG apparatus responds to the amount of sodium delivered. That throws people off like crazy. Think of it instead as flow through the system. If there's lots of flow, the switch is pushed to off. If there's not a lot of flow, gravity pulls the switch to on. Commit that part to memory, the rest should make physiologic sense. The JG apparatus makes renin. Renin turns on Ang2, and Ang2 turns on aldosterone. Now, obviously, there's more to this pathway, but this is the parts that actually matter. What aldosterone does is turns on the ENaC channels that absorb sodium and wastes potassium. It also happens to activate channels that dump acid and resorb bicarb. This is set up so that aquaporins can do their job. Aquaporins are mediated by ADH. Aquaporins absorb water. The idea is that aldosterone stimulates the reabsorption of sodium. Water follows salt. So as sodium is reabsorbed by aldosterone, ADH inserts aquaporin channels and water follows the sodium. We'll see how this makes sense in just a second. Work through it with me. We're going to start at a state of flow through the renal artery. I take you and I throw you in the desert. For 3 days, you have to walk back. You have no food, no water, no shelter. When you get back, you are going to be hyponatremic. And what is your volume status going to be? You're going to be volume down. The flow through the renal artery is going to be decreased. The flow across the glomerulus, the GFR, will be reduced. Flow through the system will be reduced. So the switch will fall to on. renin will go up, Ang2 will go up, and aldosterone will go up. Sodium will be absorbed more than before, so there'll be less sodium in the urine. Because you're volume down, ADH wants to make you volume up, so the amount of water will be reabsorbed will be increased. Sodium absorption up, water up. The goal is to hold on to as much water because you're volume down. If there's not a lot of sodium left in the urine, but there's not a lot of water left in the urine, your urine osmoles, the tonicity of the urine, will be high. This all makes sense. If you're volume down, the body's trying to hold on to as much fluid as it can. So there's not going to be a lot of volume in your urine. It's going to be concentrated. And the body's going to try to hold on to a lot of sodium, so there won't be very much sodium in your urine either. In the volume down state, your urine sodium should be low and your urine osms should be high. See this as a surrogate for aldosterone and ADH. If everything is working, the urine sodium is a surrogate for aldosterone. If the urine sodium is less than 20, aldosterone is doing its job. See urine osms as a surrogate for ADH. If ADH is reabsorbing the water like it's supposed to, the urine osms will be greater than 300. Let's just flip this around and see if it works again. We take you, before you were dumped in the desert, and have you chug 2 gallons of Gatorade. Not water, because that can kill people like it did to that woman who drank water for the weed 3 years ago. We feed you Gatorade. Your volume is going to expand. The amount of flow through the renal artery will increase. GFR will increase. Flow through the system will increase, pushing the switch to off. Renin will go down, Ang2 will go down, aldosterone will go down. The amount of sodium absorbed will go down. So the amount of sodium that ends up in the urine will increase. Because water follows salt and your volume is now up, ADH is turned off, so there's few aquaporin channels, which means that sodium is being lost, as is water. Which means that in the volume expanded state, the normal response of the kidney will be to increase the urine sodium and dump water. If the person now has a syndrome of inappropriate ADH, that is, the person is euvolemic, but ADH is still on. They are volume expanded because ADH keeps bringing in more water inappropriately. The body is going to sense flow through the system. That's increased, GFR is up, flow through the system is up, the switch is off, renin is off, Ang2 is off, aldo is off, sodium reabsorption is off. Aldo is off, so the urine sodium is high. In the setting of SIADH, the urine sodium will be elevated greater than 20, implying that aldo is off. Aldo is doing what it's supposed to do and is turning itself off. However, ADH is inappropriately turned on, even though aldo is off. So the amount of water reabsorbed into the body is high, the amount of water that goes into the urine is low, so the urine osms are going to be high, indicating that ADH is on. When you have discordant urine sodiums and urine osms, it means that there's an inappropriate activity of either aldo or ADH. This particular setting is syndrome of inappropriate ADH. When they are concordant, that is in the volume down state, there should be aldo and ADH, which you'll see is a urine sodium that is low, but a urine osms that is high. When they're concordant and they are actually you or hypervolemic, what will happen is that the urine sodium should be high, saying aldo is off, and the urine osms are down, implying ADH is off. This is teleologic because the body is not binary, but you can start to see that the tests you want to order, even if you didn't fully understand this discussion, are going to be the urine sodium and the urine osms. And so to summarize, if you've been paying attention to the numbered tests, to fully explain what's going on in a hyponatremic state, you will order a serum osms, a urine sodium, and a urine osms. If you have those 3 tests, you can pretty much determine what you need to do and what the diagnosis might be. You do that by saying, is there a true hypotonic hyponatremia or is something else in the way? Once you're in that hypotonic hyponatremia, you can use the urine sodium and the urine osms to determine the surrogate states for aldo and ADH. Understanding this system will prove beneficial as we talk about other diseases and other diagnoses like secondary hypertension. But for this, I want you to see that if you don't know what to do and you're stuck and it's the middle of the night, get a serum osms, urine osms, and urine sodium, and then, if the person is asymptomatic, treat very slowly and very gently. If you have mastered clinical skills, you're going to be able to decide, I give this person fluid, I think they're volume down. I want to restrict this person, I think they're euvolemic. And I give this person diuretics because they're volume overloaded. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.